So this is a lecture on foot anatomy with a special emphasis on movement and the bones and joints of the foot. My name is Jeff Houck from the University of Rochester Medical Center, and I did this project in collaboration with Tyler Whited from George Fox University. So we'll cover a variety of different topics that underlie foot movement. So our first topic is radiographs, and just to kind of help us understand what the basic joints and bones of the foot are. So we're going to start with a lateral radiograph. We see here the tibia, and then the fibula, the skinnier kind of shadow here, and we can see the lateral malleoli just kind of peeking in right here, and then we can see the articular surface of the distal tibia articulating with the proximal trochlea of the talus. And that's what we see here. So we can kind of outline the talus here, and we can identify the trochlea, the neck, and then the head. Okay, and then inferior to the talus, we have the calcaneus. We see the posterior aspect here where the Achilles tendon is going to attach. And then distally, we see the end of the talus here where the cuboid is going to articulate. And then we see this big knobby thing here, which forms some of the articular surfaces of the subtalar joint, and that's the sustenaculum tali. And so then there's our subtalar joint. So the talus and the calcaneus make up the hindfoot. And then if we go distally, we see a bag of bones here. Those are the tarsal bones, and they make up the midfoot. And then we see some long bones here, and these are the metatarsals and then the phalanges. And so the other thing we want to kind of notice and label are the tarsal bones. So the midfoot joint, so the hindfoot articulating with the midfoot, is really formed by two key joints, and that's the navicular with the talus and the cuboid with the calcaneus. And we can see the talonavicular joint here, and then the calcaneal cuboid joint right here. And this is the shadow of the cuboid, which is going to be a big square bone. And then the cuneiforms, which are kind of smaller, are all kind of, the shadows are kind of overlay here, and they sit just anterior to the navicular, and then also the lateral cuneiform articulates with the cuboid. And they kind of form the rest of the midfoot. And then we have the metatarsal, which has a base, a shaft, and then a head. And then we can kind of see the first metatarsal phalangeal joint there. Okay. So then we're going to switch now to a different view. So the other radiographic view that's used most frequently in the foot is the transverse view, or a superior-inferior view of the foot. And we can kind of look here and start labeling different things that we see. So we can review the bones again. So we see the tibia here, so this is medial to your left. We see the fibula right here, and then the shaft of the fibula, so lateral to your right. And then we can kind of see the hindfoot bones. So here's the talus outline, and we can see it really makes it obvious that the head is a convex surface, okay, and that's going to articulate with a concave navicular, which is in the midfoot now here. And then if we look laterally, we can see the calcaneus here, the distal part of it, and then we can see the cuboid and appreciate that's just this big square shadow here. That's all cuboid. And then the cuneiforms are these three bones right here. We clearly see two of them, and then the lateral cuneiform's kind of stuck in there, so you don't really see the joint from this angle. All right, and then we see the metatarsals, base, shaft, heads, okay, and then we see the phalanges distally. So now we're going to rename these, looking specifically at how we would classify these joints from a mechanical perspective and what kinds of degrees of freedom might be associated with each one of these joints. Okay, so let's do it. All right, so here we have the proximal bones again, same radiograph. All right, and so then if we look at the talonavicular joint, so let's kind of get these shadows going. I mean, remarkably, we are looking at a ball and socket joint. We have a convex on concave surface, and so this would be classified as having 3 degrees of freedom like other ball and socket joints in the body, and we would expect a lot of movement at this joint, and so we would also expect muscles that control that movement, and that's what we're going to see in the anatomy. Then laterally, we see something quite different. We see a planar joint between the calcaneus and the cuboid. And so we know that isn't associated with a lot of movement, so we might expect ligaments that stabilize that transverse kind of planar joint, and that the lateral side of the foot would have less motion than the medial. Basically, we see the same kind of thing at the rest of the midfoot joints and the midfoot kind of tarsal, metatarsal joints. We see all these kind of planar, flat surfaces, which suggests that supported by ligaments, they're mostly stable and there's not that much motion in the midfoot. And then distally at the metatarsal phalangeal joints, we kind of see these ellipsoid joints here initially, which are convex on concave, but really allowing 2 degrees of freedom, which would be flexion extension and abduction. And then distally we have the hinge joints of the phalanges. Okay, so then now we're going to name the compartments of the foot and then label what's inside of them. So we're going to start doing that by just looking at this mid-sagittal slice. So we can see the tibia, some muscles of the deep compartment of the leg, and then the talocrural joint. So what we're going to do is look at an axial slice somewhere about the mid shaft of the tibia. And what we can see here is the outline of the leg, medial to the left, lateral to the right. The tibia is labeled in the T, and then the fibula with the F. We see this dark line here, which differentiates the subcutaneous tissue from the muscles. We can kind of see a big circle here and a big circle here. That's the medial and lateral gastroc muscles. Okay, and then we see these tendons and muscle, tendon and muscle, tendon and muscle here, and those are some of the muscles of the deep compartment. But before we label those, we have to kind of name or organize the compartments. So they're organized by intermuscular septum. So those septums are drawn in here. The first one we'll name is the transverse intermuscular septum, which runs from the tibia to the fibula. And we can kind of see that there. And that's under the green arrow. And then we're going to identify the posterior intermuscular septum, which runs from the fibula to the skin. And then the anterior intermuscular septum, which also runs from the fibula to the skin. And so then we have these different compartments that are defined by those septum. And we're going to go through those now on an axial slice of a cadaver specimen. So here's our cadaver specimen, and we look here, we see that this is the fibula here, so we know this is the lateral side off to your left, and then the medial sides to your right, because there's the tibia, so we have tibia and fibula, and then there's a intermuscular septum right here, okay, and there's another one here coming off the fibula, and then there's one running from the fibula to the tibia. So let's label these. So we have just this intermuscular septum, which is part of the syndesmosis between the tibia and fibula. And then we have an anterior intermuscular septum running from the fibula to the skin, and a posterior intermuscular septum running from the fibula to the skin again. And then we have a transverse intermuscular septum running from the fibula posteriorly to the tibia posteriorly. And now we'll kind of label the compartments. And so we see this is the anterior compartment, in the anterior portion, anterior to the syndesmosis. And then we have the lateral compartment between the anterior and posterior intermuscular septums. And then we have the superficial posterior compartment, which is the lateral mediogastroc. And then look at the large soleus muscle here. And then anterior, or deep to the soleus muscle, we have the transverse intermuscular septum, and that then the muscles and nerve and artery in there are the deep posterior compartment. So here we see the superficial posterior compartment, triceps surae muscle, and then we have the lateral mediogastroc. We're going to reflect back the gastroc, and we see the substantial soleus muscle deep to that. And then we're going to point out the plantaris tendon running medially along the Achilles tendon. We reflect back the tendon, and we can kind of see the bursa, the retrocalcaneal bursa underneath the probe. And then the mid-substance of the Achilles tendon under the probe as it runs from the triceps surae to its distal attachment. So here we'll take a close-up view of the distal attachment of the Achilles with a special emphasis on the posterior superior aspect of the calcaneus, which might dig into the tendon, and that's where the retrocalcaneal bursa can be irritated. So we see here the distal Achilles tendon attaching, reflecting that back. The probe is now on where the bursa would lubricate that connection between the calcaneus and the tendon, and then there's the attachment. Some takeaway points from those videos. So the first is that the superior posterior aspect of the calcaneus is prominent. Sometimes it can be called a Haglund's deformity. It can irritate the retrocalcaneal bursa. And then if you look at the sagittal plane view of the Achilles tendon and where it inserts and how far posterior it is to the malleoli, you can appreciate that it's a large moment arm, so it gives the Achilles tendon quite a lot of leverage. And so the gastrocsoleus is really the major plantar flexor of the ankle joint. And then also remember that the gastroc crosses the knee, but the soleus is only a single joint muscle. So we just want to mention a few of the muscles in the anterior compartment of the foot. Here we list them: the anterior tibialis, extensor digitorum longus, and extensor hallucis longus, but we want to make a couple observations about the anterior tibialis relative to the arch of the foot. Essentially, all the muscles of the anterior compartment dorsiflex the ankle, and the anterior tibialis muscle is unique in that it both dorsiflexes and inverts. It dorsiflexes the ankle but inverts the mid-tarsal joints. And how does it do that? Well, its distal attachment is on the plantar surface of the base of the first metatarsal and the medial cuneiform. So remember, that's on the medial side of the foot, but it's also on the plantar surface. So as it contracts, that wraparound effect causes a leverage for the tendon to actually invert the forefoot. Okay, now we're going to move into talking about the lateral compartment muscles, which really is the fibularis longus and brevis, innervated by the superficial fibular nerve. So here we see the anterior compartment muscles have been reflected, and then I'm putting my probe on the fibula. So that's the fibula there. So this is the lateral side of the foot, and the video is going to show the fibularis longus and brevis tendons and their attachments. So there's the longus tendon running deep to the fibular retinaculum and then through the cuboid tunnel to the medial side of the foot. And now we're going to look at the brevis. So then the brevis running immediately posterior to the malleoli and then through the fibular retinaculum. And then now distally, we can kind of see it's going to attach to the base of the fifth metatarsal. And he's going to now pick it up again under the probe, and we can kind of see that attachment to that fifth metatarsal. So in this next video, we're going to show how pulling on the tendons moves the forefoot. So here we're kind of showing the retinaculum being pulled back. This is a fresh cadaver. And then there we have the longus, so the fibularis longus going to the fibular retinaculum, and then there's the brevis channel. Essentially then we're going to pull on the longus going underneath the foot, and so you can kind of see it wraps around the foot and everts the forefoot and also everts the subtalar joint. So now we're going to do the same thing to the brevis. So you can see the brevis there attaching to the base of the fifth metatarsal. We pull on it and it kind of everts the forefoot. Okay, this next part of the video, what we're going to do is the foot is, plantar surface is facing upward, and what's going to happen is we're going to pull on the fibularis longus again and watch what happens to the first metatarsal. And notice when we pull on the longus tendon, we're going to see the first metatarsal plantar flex. So here we're pulling on the first metatarsal, and then we can kind of see how the foot everts and the first metatarsal plantar flexes. And so that's the effect of the fibularis longus on the forefoot. So here we'll review some key points from the lateral compartment. The first is the importance of the fibular retinaculum in keeping the tendons from displacing distally. When it's torn, it becomes an issue clinically. The other is that the fibularis longus and brevis both plantar flex the ankle and they evert the subtalar joint and the midfoot joints. And finally, the fibularis longus tendon, surprisingly, plantar flexes the first metatarsal because of its attachment on the plantar surface of the first base of the first metatarsal and medial cuneiform. Okay, so now we're finally moving into the deep posterior compartment of the leg, and these extrinsic muscles that run into the foot are really the key muscles that support the medial longitudinal arch, because they both plantar flex and invert. And so the muscles include the flexor hallucis longus, the posterior tibialis muscle, flexor digitorum longus, and then the tibial nerve supplies these muscles, and then there's an important arterial supply in the tibial artery, which also runs inside this compartment. So we'll start by remembering this acronym, Tom, Dick, and Harry. So Tom standing for tibialis posterior, Dick for flexor digitorum longus, A and the N are the tibial artery and nerve, and then Harry's the flexor hallucis longus. And this is, you'll notice in the video, this is the order that these tendons are in at the posterior aspect of the malleoli as they run into the foot. So let's watch the video now. So here's Tyler showing us the medial side of the foot. There's the Achilles tendon, and then we can kind of see the transverse fascia, which he's going to pick up here in a minute. So that's the transverse intermuscular septum there, and then we're going to see the tendons here emerging through the tarsal tunnel. So that's the fascia covering that, which forms the tarsal tunnel. And then he's going to now pick out the different tendons running through the tarsal tunnel, that being the posterior tib to start with. Now in this video we see the abductor hallucis has been dissected, and we can see how substantial that is on the medial side of the foot, covering the tendons and nerves running into the foot. And there's the distal attachment of the abductor hallucis muscle, which is a foot intrinsic, and then we'll kind of go on the other side, and now we can see the posterior tibialis muscle there, the tendon running around the medial malleolus, and that's showing it attaching into the navicular. And then that's the flexor digitorum running under the abductor hallucis and then to the toes. And then there's the powerful flexor hallucis longus running underneath the sussinaculum tali through the tarsal tunnel into the foot and along the first metatarsal. So now we have the reflection of the abductor hallucis muscle. That's the attachment of the posterior tib, the anterior tib, and that's plantar fascia. And now it's being reflected, and you're seeing the flexor digitorum brevis and then some of its tendons going distally. And now we're going to go identify where the flexor hallucis longus there, and then is crossed by the flexor digitorum longus to get lateral to attach to the distal phalanges of 2 through 5. And here we're taking a closer look at the attachment of the posterior tib, which is the navicular and the medial cuneiform. That's outlined there, and that's the navicular tuberosity that's pointed under the probe. Okay, so this is going to be really fun. We're going to look at how pulling on these tendons moves the forefoot or midfoot joints. In particular, we're going to focus in on how it moves the talonavicular joint. So the way you can see that is when you're watching the motion occur, focus in right here. So this is the posterior tibialis tendon coming down, attaching to the navicular here. This is the anterior tib tendon on the medial side. And you can kind of see the flexor hallucis longus tendon here kind of running underneath the first metatarsal. Okay, and so what I'm going to do is pull in each tendon like I did in one of the previous videos, and then you can see what kind of motion is occurring in the forefoot. So here we go. So here I'm pulling on the posterior tibialis tendon, and you can kind of see the navicular tuberosity pulling up toward the medial malleoli, causing inversion and plantar flexion of the forefoot. And that's that ball and socket motion that we expect to see at the talonavicular joint. And now we're doing the same thing, same kind of pulling on the flexor digitorum longus muscle. And now you can kind of see the lateral foretoes are being swept, across the floor. And now we're kind of pulling on the flexor hallucis longus, which is running deep to the sustaneum taili, and you can tell it's really compressing and flexing, compressing the talonavicular joint and flexing the MTP joint, or metatarsal phalangeal joint. Okay, so now that you've seen the movement that occurs using the cadaver specimen, one of the things that might come up is it seems like the synergist muscles, the posterior tibialis and the flexor digitorum longus in particular, have kind of similar actions, and then the flexor hallucis also has some ability to support the medial longitudinal arch. But how do they all compare, and synergistically do they do the same thing? So we can look at, biomechanically, we can look at two things. One is their moment arm, and secondly, their physiologic cross-sectional areas. And that's what this graph or table is talking about. And this is from a paper in 2008. A little dated, but we're talking about anatomical structure, so it probably doesn't change that much. So essentially the average here, we look at the posterior tib versus the FHL versus the FDL, their PCSA, or their ability to generate torque or force, can be compared using their physiologic cross-sectional area. And we kind of see here across these 5 studies essentially that the posterior tib is significantly higher, twice as much PCSA as the FHL, and 3 times more or greater than the FDL. So in terms of capacity, the posterior tib just has much more capacity in terms of torque generating ability, and then its moment arm at the talonavicular joint is also larger than the other muscles. So essentially it has the mechanical advantage. So a key point of this is that the posterior tibialis muscle, because of all this, is really the significant muscle supporting raising of the medial longitudinal arch, and that the FHL really functions at the first MTP joint with that compressive kind of loading mechanism that you saw in the video. And then the FDL, although it could compensate somewhat for a weak, say, posterior tibialis muscle, it just doesn't really have the structure to fully compensate for that muscle. So loss of the posterior tibialis muscle, even though it's synergistic with these other 2 muscles, is much more significant than you might guess. So in review, the key points is that the posterior tib, the anterior tib, and the fibularis longus, which we'll kind of show you when we get into the deep foot, all attach on the medial side of the foot. So they're all supporting that ball and socket joint at the talonavicular joint on the medial side of the foot. In sequence, from anterior to posterior, the deep posterior compartment muscles going through the tarsal tunnel, just medial to the medial malleoli, are in order Tom, Dick, and Harry, meaning posterior tibialis, flexor digitorum longus, nerve and artery, and then the flexor hallucis longus. And the last 2 points is the deep posterior muscles support the medial longitudinal arch by controlling movement at the subtalar joint, and then the mid-tarsal joint, which is the talonavicular and the calcaneocuboid joints. The largest contribution is made by the posterior tibialis muscle. Okay, so now we're going to move into the foot intrinsic muscles and ligaments. And so we're going to divide it up into talking about muscles, ligaments of the foot, and then the plantar fascia. And so the muscles of the foot here are listed. You can kind of look at this. This matches most of your anatomy textbooks. We're going to focus in on just a few of these in terms of IDing these in the videos. It'd be the adductor hallucis muscle, which you've already seen, and then the flexor digitorum brevis muscle. In terms of foot ligaments, we're going to really focus in on really the biggest, most powerful ligament that's been identified in the body, besides like the intervertebral disc, and that's the long plantar ligament. So we'll kind of show that on the lateral side of the foot, which supports the calcaneocuboid joint. And then we'll also, on the medial side of the foot, show how the spring ligament's key to supporting the medial longitudinal arch. And then finally, between those 2 ligaments, which the spring ligament's medial and the long plantar ligament's lateral, the short plantar ligament's kind of in between those 2, and we'll kind of show how that kind of also supports some on the medial longitudinal arch. Okay, in this video, we're going to first start off by peeling back the plantar fascia and the intrinsic muscles of the foot. Then we're going to identify some extrinsic muscles of the foot and push them out of the way, and then look at the ligaments that are laying on the plantar surface of the arch of the foot. So here we go. So that's the abductor hallucis muscle. That's the plantar fascia. And I just want to note something about the plantar fascia, so we're going to go back a little bit here. Note that this is the medial calcaneal tubercle is where the plantar fascia arises from, not the lateral. On the lateral tubercle, there's the abductor, the lateral compartment muscles, which is like the abductor digiti minimi and the flexor digiti minimi are coming off that lateral side. So if you're palpating for plantar fasciitis, you're going to be on the medial tubercle, not the lateral. And you can kind of see that in the picture right here. This is the medial tubercle of the calcaneus. Okay, so let's keep going now. So there's the abductor hallucis. Again, there's plantar fascia reflected. And then we can kind of notice here, if you look here, the flexor digitorum brevis really attaches to the plantar surface of the calcaneus, but it also attaches quite well to the underside or the deep part of the plantar fascia, and these are those little tendons. And so now that's being reflected, and then that's the abductor compartment there for the digiti minimi. That's the quadratus plantae that's then being reflected. And then now we're reflecting back some of the extrinsic muscles. We'll just pause for a sec. This is the posterior tibialis muscle attaching to the navicular tuberosity. And we can kind of see that reflected there. And then there's the flexor digitorum longus, and that's being reflected. And then there's the hallucis running underneath the acetaculum tali. And all those are pulled out of the way. And then now what we're going to kind of see is some of the ligaments. And so first we're going to start here on the medial side, so that's the spring ligament there. And then there's the short plantar ligament. And then here's the long plantar ligament. We're going to stop there just for a minute. You can kind of see how wide and long it is. So it's going from the calcaneus, and it's going to go over the fibularis longus tendon, which will show you the tunnel for that in a second. And then it's going to jump over that tendon, forming that roof of that tunnel. And then it's going to attach on the second through fifth bases of the metatarsals. So you can kind of see the tendon there. The probe's being run along that kind of wide. Now Taylor's grabbing that tendon to just show you how wide it is and thick. Okay, and then he's going to run his probe now. That's the longus. And notice how the longus courses across the foot and then attaches on the lateral side of the medial cuneiform and first metatarsal base, and that's the tendon attaching right there. Okay, after it runs, that's the short plantar ligament, and then that's the spring ligament that he just identified. Okay, so now we're going to take a second look at these intrinsic muscles and the ligaments of the foot using the fresh cadavers there where the abductors being reflected. Now the plantar fascia and flexor digitorum brevis are being reflected. Now the extrinsic muscles, FDL and FHL, are being reflected. And then we're getting now to the ligaments of the arch of the foot and the lateral side of the foot. And we can see now there's the long plantar ligament being pointed out in the probe. And then now the short plantar will be identified under the probe. And here we kind of slide the probe underneath there and kind of show the ligament running from the calcaneus to the navicular. And then now we have another view with more of the extrinsic muscles cut away. And I'm going to I'm just kind of poking around at the deltoid ligament for a minute, just kind of showing how its relationship to the talonavicular joint. But the tuberosity of the navicular is really prominent there with the posterior tib tendon. And now what I'm going to do is we've dissected the superior part of the capsule of the talonavicular joint. So I put my probe into the talonavicular joint, and then I'm pushing it through the capsule on the bottom, and that's really highlighting where the spring ligament runs from the acetaculum tali to the navicular. Okay, so now that we've completed our discussion of the intrinsic muscles of the foot and foot ligaments, we want to move to a special discussion about the plantar fascia. So the plantar fascia arises from the medial calcaneal tubercle, and inserts across all 5 middle phalanges, and on the first digit, the proximal phalange, essentially kind of supporting really the whole arch of the foot. So in this video, we're looking at the plantar fascia attachments, so we can see the plantar fascia with just the sub-Q removed, the medial tubercle, and then the lateral muscles coming off the lateral tubercle. We see the strands going into the phalanx. This is the extrinsic muscle tendons, kind of coming into the attachments on the plantar surface of the phalanges, and then the plantar fascia going lateral, and that's the FDL, going lateral to attach on that middle phalange. Okay, so now we're going to use the fresh frozen video to kind of show these attachments again. You see pretty much the same view as the embalmed cadaver, and we can kind of really see the split in the distal attachments of each strand of the plantar fascia as it's going to the each phalanx and kind of attaching distal to the MTP joints. And so now what we're going to do is kind of try to show the function of this tendon. So we're kind of peeling it back and showing the flexor digitorum brevis's attachment to that. And there you see the FDL coming in underneath it. So there's this real interconnection between all of these structures. All right. And then now we're going to kind of show the function. So I'm going to pull on the proximal part of the plantar fascia and then dorsiflex the big toe. And when I do that, what you're going to see is that the arch raises a little bit with that dorsiflexion. So that's the windlass mechanism. When there's tension or stabilization in the proximal part of the fascia and you dorsiflex the big toe, that tension then causes the metatarsal head and the heel of the calcaneus to be drawn together, raising the medial longitudinal arch. So in this final slide of the actual cadaver specimens, we're going to use the same kind of fresh frozen cadaver to show you how just moving the tibia raises and lowers the arch. And in other words, the rotation of the tibia kind of loads the joints of the foot and ligaments of the foot to cause the arch to raise and lower. So as we watch me internally and externally rotate the foot, you can see how that causes an interaction between the talus and the midfoot, and then you get that talonavicular joint motion that ends up raising and lowering the arch, where internal rotation lowers the arch and external rotation raises the arch. It's also worth mentioning that this is completely independent of muscle control. Just here passively rotating the tibia into internal-external rotation causes the arch to raise and lower. So now we'll summarize support for the lateral and medial longitudinal arches. We'll start lateral. Remember that the calcaneocuboid joint's a planar joint, so there's not much motion, so there's some intrinsic support there already, but it gets support, muscular support from the fibularis brevis, and some from the longus, but that really acts on the medial side of the joint of the foot as well. And then you have the long and short plantar ligaments, with the long plantar ligament being one of the most substantial ligaments in the body, supporting the lateral side of the foot. And then you have the medial longitudinal arch, which has its underlying starting point as a talonavicular joint, which is a ball and socket joint, which has significant amount of mobility. All of the deep posterior compartment muscles support the medial longitudinal arch, in addition to the fibularis longus muscle, which we saw its attachment that runs across the foot from lateral to medial. And then the foot intrinsic muscles also are well aligned to support the arch. And then the keystone, though, being in terms of passive support, being the spring ligament. And then we saw a special mechanism associated with the plantar fascia called the windlass mechanism. And finally, we demonstrated that internal external rotation of the tibia causes the arch to raise and lower, and you'll study this much more in different classes like biomechanics. I want to recognize my esteemed colleague who helped me with this, Tyler Whited, George Fox University stud, and the great time that we had making this video. We both hope this will benefit you and your patients.